Welcome to Cups and Courage, the podcast. Today's guest is Georgette Oni. Georgette is one of a handful of reconstructive and plastic surgeons in the UK who are also dual qualified in surgical oncology. Cups and Courage, the podcast. Welcome, Georgette.
Thank you.
Thank you for being here. As tradition on our Cups and Courage podcast, we ask every guest to bring in their favourite biscuit. So I know it's in here. It's a dependable rich tea.
It's got to be dunkable.
Is that why? That's your main, yeah, I mean, these are they dunkable though? They not just get a bit soggy?
They do.
And we're okay with that. We're okay with that. Brilliant. Thank you. Thanks for being here. It's really lovely to have you.
Pleasure.
Our second tradition is we like to ask our guests a really deep and quite difficult question to start us off with. But what does courage mean to you?
That is a very difficult question. That is a very deep question. I guess there's lots of definitions, right? But when I look professionally, that's pretty much every patient that comes through my door. But it's not just the patients, it's the people that are supporting the patients. I'm not just meaning myself, but we have like a whole support mechanism in the NHS in terms of nurses, in terms of allied health professionals, in terms of charitable sector involvement. So there's a whole bunch of people who do a lot for patients going through this journey, and it takes something out of them. So I think most people that are involved in cancer care in this country, they do have to have an element of courage within them. So that's my professional take. But obviously, there's lots of examples, in your personal life, and you don't often think about yourself as someone that has courage to do things. But I guess there have been time points where I have had to step out of myself and do things which. It would have been nice just to stay at home and sit on my sofa. To not have
to do the thing.
Yeah,
I get it. Yeah, we get such richness in those, those, albeit moments. Quite, but simple question that we ask, and people go, because it threads through a lot of how we move through life, I think, with courage. So Georgette, you're with us today. You are one of a handful of surgeons in the UK that has a dual specialism.
Yeah.
Before I get that wrong, because I will, are you able just to give me a bit of a...
Sure. So I'm actually a plastic surgeon. So I did all my plastic surgery training. And then as I was going along, I became interested in breast reconstruction. And there are a lot of plastic surgeons that do breast reconstruction. It's very standard in our training programme. But one of the things that I saw as I was going along is that we're involved in the reconstructive element, but not so much in the oncology aspect of it. So I went and did some more training in the oncology, so that I could be the surgeon that takes away the cancer, manages the cancer, as well as does the reconstruction. So there's a growing number of plastic surgeons that do that. But by far, the majority of surgeons who do that role in this country are breast surgeons who train through a general surgery pathway.
Okay, that makes sense. Thank you. I want to deep dive straight into this, partly because it's not my lived experience. So I had a flat closure after a double mastectomy. And I'm always really interested to understand the different types of reconstruction, because I hear a lot from people on our podcast. There are different types of reconstruction. So can you talk to me like I'm a toddler a little bit? Is that okay?
I won't talk to you like you're a toddler. However, what I will say is that there are different types of reconstruction, absolutely. And when I have a patient in front of me in clinic, the way I start by explaining it is that there are two main ways. So that's either using parts of your body, essentially, or using implants. And very occasionally we use a combination of both. And we used to use a combination of both quite a lot many, many years ago. But by and large these days, we tend to use one or the other. And really, some of it is to do with what is available to you in terms of your options. Some of it is to do with personal choice. And some of it is to do with whether it's a safe thing for you to have at this time in your pathway, in your cancer pathway. So there's a lot of discussion that goes around, that's involved, I would say, in reconstruction, form of reconstruction, timing of reconstruction. Because I think the other thing is that a lot of people think that reconstruction is something that can happen, that doesn't happen at the same time, for instance, as you have your cancer removed. But actually, increasingly, we are starting to do that. So if we can, we try to do an immediate reconstruction. And also the other thing is a lot of people associate reconstruction with mastectomy. So you take away all of the breast tissue and then you reconstruct the breast. But actually a lot of what I do is partial reconstruction. So taking away some of the breast and then reconstructing what's left behind. So that's either by bringing in fresh tissue or by rearranging what's been left behind.
That's not the same as a lumpectomy, though, is it? So, or
yes,
it is.
It's part of that. So you have a
right.
lumpectomy, and then you have some form of partial reconstruction because you now have a lumpectomy defect.
Yeah, I understand.
So reconstruction can be total, can be partial, can be using your own tissue, can be using implants, can be done at the time that you have your cancer removed, can be done afterwards. Can be a combination of implants and tissue, and a lot of it is a lot of discussion, and it's a shared decision, I would say, between yourself, the patient, the managing team in terms of the oncology, etc. So there's a lot that goes into it, but ultimately, centre of it all is the patient.
It's interesting because actually, as you're talking, there's a lot of information. I'm listening and I'm going, wow, so I would have to understand if my body type supported this, if the cancer supported this, if my longevity, whatever. Yeah. Lots of different things that I have to understand to be able to make an informed decision. But potentially you as a clinical professional, you're going to have a lot of that information to hand. You're going to know it anyway. So I would imagine a large part of that job is bringing it to life for the person who's sitting in front of you and getting them on the same page and making sure that they understand.
Yeah. And that's tricky, right? Because I've just hit you with a sledgehammer and told you that you've got cancer.
Yeah.
You may be going through chemotherapy. And we all know that there's a lot of changes that happen with chemotherapy. And so you're now asking someone to take in a huge volume of information, digest it, make a decision. And sometimes that's got to be done within 4 weeks because that's our cancer pathway, right? We've got time points at which we do certain things because we believe that gives you a better outcome. So there's a huge amount that happens. There's a lot. And that's why when we started off this conversation, we were talking about courage. But it's not just me imparting information. There's breast care nurses, there's reconstruction nurses. There's a lot of other people that get involved. There's prosthetic fitters. There's a lot of other people that get involved to help the patient to digest that information to make a decision.
And you're right. And I think somebody who is going through it, just had that sledgehammer of a diagnosis, actually they may have previous narratives in their head about, maybe they've known someone who's gone down one pathway. So that would be their assumed what they would think just happens. Yeah. And it is almost, I talk about cancer like you're going through a gate that you can't go back. And the minute you go through it, it's like, oh, it's a whole different world of information and how much you're going to look around and take all that in and how overwhelming that is and how we deal with all of those different stimulus all the same time with a bit of sometimes a time pressure attached to it as well, right?
And that's why I think as well, having different people that are supporting, professional or otherwise, is actually quite important because sometimes you need information from a doctor, but sometimes you need it from a nurse. Sometimes you need it from a psychologist. Sometimes you just need it from someone who fits prosthetics, right? To decide if you're going to have a reconstruction at all or whether you think you would manage with just having an external prosthesis. So actually, it's not just about we're all in a room doing this.
Yeah.
Sometimes it's like, okay, I've given you some options. It's a lot. Go away, have a think. And if you need to speak to this person, let's get you there. If you need to speak to that person, let's get you there. But you go away and decide. And here are some suggestions what I think might help you with that decision.
Can I ask potentially a tricky question? Nobody ever says no, but I say it. No. So on this podcast, we've had ladies bringing us varying experiences. So some people have felt fully supported in that kind of informed decision making and signposting to the right people and making sure that they've got access points to have all the information they need to be able to take the next step. And some people have said, no, I didn't, for a number of factors, but that was their reality in that space. Why is it, do you think, that we have a bit of a divide between patients' experiences across the UK? And I know you can only speak from your experience, so,
Yeah, I think this is the reality of the situation. Okay, so we see that even in data that we collect. So there's big sort of national audits which show that there's variation in the country in terms of access to reconstruction, types of reconstruction. We know that even within a department, there might be variation in access. I think so. There's the sort of structural things that might cause problems, but then there's also the understanding as well. And some people may feel that they haven't had access to stuff when actually they have. It's just that they've not been able to process it because of what they're going through.
Yeah.
And then there's also the unfairness of it, right? Some people may want something, but they can't have it because oncologically it's detrimental. And so actually it makes no sense to have reconstruction now, because the type of reconstruction you need, for instance, might open up a whole load of complications, which delays you having things that you need for your cancer treatment, which ultimately is going to affect your long-term survival. So there's the unfairness of that as well. And there's the unfairness of just getting cancer at all, right? And the overlay of all of that. So I think, yes, there are structural problems. There are regional issues. There are things that we're aware of and that we're trying to address from a professional standpoint. But there are things that we don't actually have control of either. So it's a difficult situation all around. But I think we're doing what we can from our perspective in terms of broadening access. There are certain forms of reconstruction that are only available in certain kinds of units. So I said at the beginning, I'm a plastic surgeon. We are really the only group of surgeons that do microvascular reconstruction, for instance. So that's when you detach bits of the body. So tummy is the common one to rebuild a breast. There isn't a plastic surgery unit for every single breast unit in this country. So in order to access that form of reconstruction, some patients have to travel, and they have to travel quite far. And then there's the whole recovery with that, and the fact that you might be having to go back and forth. So some patients might be presented with that, and they may go, that's not something I can deal with. That's not something I can cope with, either financially, emotionally, physically. And so they opt for something else that they would rather have not have had. But their situation is such that they can't access it.
Yeah, I understand. And I think that there is such diverse nuances between those individuals, and how someone shows up in the moment and how they're dealing with everything that's given to them at that moment. But I think to your point, and I don't think I've really considered that. The perception is that the information is not there, but perhaps there is more information. But because of the trauma and because of the stress, we can't hear everything clearly. Or however we deal with overwhelm and overload, we don't have... We can't, strip all of the stuff away, which is why a lot of the time we're told, bring someone with you if you can. Yeah. I never did. I never did.
I think bringing someone is quite useful.
Yeah.
Because there's always lots of questions when you leave that room. And there'll be lots of people on the phone to you going, oh, what happened? What do they ask you? What do they tell you?
Yeah.
And you're just in like a shock, I would have thought. And a lot of what we say does not actually compute. I always write to the patient afterwards. Okay. And I always give them a really detailed summary of what we discussed. But it is a lot of information. It's verbal, it's written. I often tell patients, we're going to give you a tree now, because essentially that's what it is. You get reams and reams of information. I think one of the advances hopefully that we're going to move into is actually the way that information is delivered. I mean, I think commonly it's either verbal or written, but obviously we're moving into an artificial intelligence kind of era, and I expect there'll be different ways and different formats in which that information is given that you can go back to repeatedly. In a way that gels better with you and your understanding. I
would imagine. I think that's great. I think it's really important, because I think we've got to utilise AI anyway, rather than ignore that it's going to, know. So I think that's great. But what it sounds like is probably almost more prevalent that the way in which information is delivered is really holistic and kind, and that time is taken. That feels like quite a lot of responsibility on the deliverers. Yeah. Because you've got to give all that information, but you've got to give it in such a way that someone feels heard and listened to and understood and human in that moment, where actually for you, potentially that's, the 12th person you've seen in a day and delivering very difficult information to and receiving it differently. So
I think one of the ways I handle that, and that is very true, I can sit in a clinic and I will tell 7 women or 8 women in a row, you've got cancer. But the way I normally try to approach that is to find out a bit about them, right? So once you've found out a bit about them, you're going to know what they can take at this moment and how to pitch it. It's not always going to be perfect, but at least it allows you to sort of flex a little bit depending on who you've got sitting in front of you and who they've got with them as well.
We only come from our own experience of things, and I'm hearing you and I'm going, I wish you were my surgeon. I wish I had a bit of a tricky time in my first bit, and what you're talking about, that key element of making sure that you pay attention to the individual, what's important to the individual, and read between the lines, and trying to paint a picture of that human outside of a diagnosis as well is key. I think, and sometimes, I mean, I've spoken to people where the perception is that's not happened, and I think.
And I think it's a both ways thing as well. Yeah. Because people have perceptions of what doctors are supposed to be like as well, and what doctors want to know.
Right.
So if doctors don't ask, they won't tell sometimes. And we see that a lot around things like the medical management and the effect that it might have on patients' lives. They're not very good at saying, oh, it's completely knocked off my libido. It's not allowed me to sleep, what have you.
Yeah.
Because in their mind, they think, well, I'm very grateful.
Yes.
Because I've been given this treatment. But actually, these are conversations that need to be had. Otherwise, we can't improve, or at least try to improve, the experience that you're having.
Yeah.
And similarly, it might be around what happened. So one of the things I commonly discuss with women who are a good candidate, for instance, for having a lumpectomy with a rearrangement is I'll ask them, are you happy with how your breasts look? Would you prefer if they were a bit smaller? Would you prefer if they were the same size, etc.? Questions like this.
Yeah.
Because actually it can influence what kind of surgery I ultimately offer them. Because, the way I look at it is this is going to be a terrible time. If after all of this you can move on into some semblance of a happy life, and that the surgery can help facilitate that, then we need to just get that right first time if we can.
Yeah.
We can't always. A lot of time we can't, but we try.
Yeah.
But can we get that right first time so that you're not having to continuously come back to the hospital for things?
Yeah, I get that. Okay, so in your kind of professional world, when you're having these conversations, obviously there are different options. There are different reconstructive options, but there are also surgical options to potentially not reconstruct.
Yeah.
What do you see? I know it's hard to kind of give a ratio, but do you see within the women that you treat, do you see predominance in surgical choices?
So I think that what we see is that younger women do tend to have slightly more aggressive disease, are more likely to probably need a mastectomy as a result of that, and they are more likely to take up a reconstruction. Older women tend to, so they enter into a screening program right as you get older. So the aim of that is to pick your cancers up quicker, so that the treatments that you need are less aggressive. So they tend to be in a more of like a lumpectomy group. And so then it's more of a discussion about does that lumpectomy happen on its own, or does that happen in conjunction with some form of partial reconstruction, as we discussed earlier. So you do see that. That being said, there are some reconstructions that are happening in 70-plus-year-olds.
Right.
And there's lots of, younger, what we call premenopausal women who are not having reconstruction at all. And there are many reasons for that. But a lot of it is to do with lifestyle, what they see as the value, I guess, in their breast and having a reconstruction. What they do, lifestyle is a really big thing in that phase of your life.
Yeah, which is why it's vital to have ask those questions that you were talking about, because if you can't ascertain what is important to somebody outside of the physiological body, then the choice is, we might assume based on our own bias.
Your own perceptions.
Yeah.
And I think it also helps when you have to say to someone, well, you can't have that form because some patients will come in and they'll go, right, well, I want this type of reconstruction. And I'll go, okay, let's find out a little bit more about that. Let's just discuss why. Let's do an examination, and then let's see if that's going to be suitable. And there will be a fair proportion of times I'll go, well, that's actually not your best option. Just this week I've had 2 ladies like that where I've gone, actually, that's actually not your best option. This is, and these are the reasons why. Do you want to explore that further?
Yeah. It's just giving space. It's creating space to have a conversation where someone can ask the questions and explore it. Okay. So you've got, potentially, if we were to separate people, you've got these younger, predominantly younger women opting for mastectomies. Why do we think that is? Do we, opting for reconstruction post mastectomies, premenopausal?
So I think that you're still in that phase of life where, for some women, they've not necessarily even met a partner, for instance. Right. They've not had their children. They're very invested in things like they like to wear, their lingerie, all that sort of thing. So just even sort of conceptualising not having anything there is really quite a difficult thing for them to have to do.
Yeah.
COVID was really bad for that because we did have to say to a lot of women who would have been good candidates, I'm sorry, you can't have reconstruction because of all the sort of constraints and things that were happening.
Okay, so they could have the mastectomies, but they couldn't have the reconstruction.
Because we had to treat the cancer, but the reconstruction added that extra level of complexity that at that time would have been problematic should complications occur.
Absolutely.
For the health service. So thankfully, a lot of those women actually came back through and had their reconstructions. But I think it's actually quite a difficult one.
Yeah.
And I think that this is why it does involve quite a lot of nuanced discussion and psychological support sometimes as well. The other thing is that if you get it very young, there may be a genetic reason why you have developed that cancer. And so you are needing to have quite aggressive surgery to try and reduce your risk of developing another one in the future because of the fact that you have a gene mutation, for instance. So there's lots of things that play into the surgical decisions that are made when you're younger.
Yeah,
there's even women that don't have cancer. They carry the risk of developing it that you're having to do mastectomies and reconstructions on, and so that's a whole other group and a whole other
prophylactic
risk reduction surgery. Yeah. And a lot of those women do opt for a reconstruction.
Let's talk about body image and how much body image, because I know we're talking about a younger generation who, if that's where prevalent reconstruction potentially might happen for a number of reasons. One of them might be where they're at in their life and partners and clothing and aesthetics and the rest of it. But how much does body image, play into the conversations that you have with people when they are having those initial?
So I think the first thing is, for me, it doesn't actually matter what your age is.
Yeah.
The question is, if you want a reconstruction, are you fit enough to have a reconstruction?
Okay.
So that's the first thing. A lot of women think they have to justify why they want one. They don't. They just need to say that they want one.
Yeah.
And then we can talk through whether it's doable or not. Because sometimes it's not doable. You can be young with a lot of health problems. It's not safe for you to have reconstruction. You can be older with no health problems. You're really fit. I had a patient who was deadlifting like 80 kilograms, fitter than me, right? Okay. And she's in her 70s. If she wanted a reconstruction, she's fit to have a reconstruction. So it is about the individual.
Yeah.
And the psychology, I'm not a psychologist. So, it's there will be some patients that you screen in a crude way that would benefit from psychological support. So I have had patients that outright have said, look, I have had a lot of issues with my body image. Growing up, it's a real issue. Now I've got this diagnosis. I don't know how I am going to ...
Yes.
These are women, clearly, that need support during this time. Oftentimes, they already have some semblance of that psychological support around them, but they probably just need that ramping up because it's not just obviously about changes in body image. It's going to be about how the treatments are going to make them feel.
Yeah.
So there are, there's a barn door group of women that you're like, you need, and I'll be honest with them. I'll go, look, you clearly have had a difficult time already. We're going to make that time harder now. Would you like us to do? And most of the time, they're going to say yes. They will. They're really happy that someone has identified that they need some extra support.
Yeah, of course.
Then there's, I call them the sort of the copers. They're the ones that will just go, yeah, I'll be fine. And a lot of the times they're not fine. Actually, they're just used to coping with everything. And the first couple of consultations, they'll be like really stoical, like really like tough. And by the time you're seeing them for the third or fourth time, there's floods of tears. And you're like, oh, thank God you cried.
Yeah, right.
Now we can help you. You're open to it now. Yeah. Let's get some things in place and let's help you.
Oh, that resonated. I'm not sure if I was expecting that to resonate so much.
Oh, right.
Yeah, but I think that's really interesting. That's easy to be able to go, okay, there's a coper, and that's someone, not a coper or not coper, right? Of course, we're nuanced, but actually at some point, how long can we cope for until we go,
Correct.
Okay, I need to take a breath. I need to just tell you what's going on really. Yeah. And then I suppose, that's where the support can come in.
It's when you hear their stories and they're like, yes, well, I do this, and I do that, and I do this, and I do that. And I'll go, but I told you you had cancer like last week. Have you actually been able to do And usually the answer is no, I've not. So you can get an inkling that they're going to need some support to just actually let go of some things. Okay, to focus on themselves.
Yeah.
Yeah,
that is interesting. Okay, I'm gonna jump over from into a reconstructive space. Do you have people that are, when it's been decided the type of reconstruction, that have really strong views about sizing that they want, or have real strong views or conceptions around what they think life is going to be afterwards, and you've really got to kind of bring them into a space of going, hang on a minute, whether that's because of a coping mechanism of, as you say, continual action or otherwise?
I think it's the reality of surgery.
Okay.
And this is one of probably criticisms of me is that I am the sort of person that will emphasize things that could go wrong.
Okay.
Because if it goes fine, great. We've said what we're going to do. It all looks fabulous. Great. But the fact is, and if you look across all reconstructive types, about 1 in 4, 1 in 5 women are going to have a problem on that journey.
Okay.
And that problem can be severe enough that they actually lose their reconstruction. So, for instance, if we look at implants, the national audit, 9% of women will lose their reconstruction for implants. Most units that do free flap surgery, depending on the type, but most units that will do microsurgical reconstruction, order of 2 to 5% are going to lose their reconstruction. And then there's the ones that don't lose their reconstruction but have a problem with the reconstruction and need revision surgery. So the people that you get it right the first time and they just crack on, I think that group is actually not as much as we would like it to be.
Yeah.
So I think preparation is really quite important. Because I find that when patients are really prepared for what could go wrong, when little things do, and most of the time it is little things, like it might be a little wound problem that needs dressing, for instance, they cope with it beautifully.
Yeah, I get that. I hear that.
And that doesn't matter whether you have reconstruction or not, by the way, because you can have problems with a mastectomy, you can have problems with a simple lumpectomy. So actually that preparation is actually quite important because most women take it in their stride then.
Can I ask you a cultural question? I'm interested from, if we're talking about white women, people of colour, do we see any trends in terms of what somebody might opt for?
So I think so we've done a systematic review on this, it's published. Okay. Non-white women don't tend to have reconstruction as often. But this is, I would say, older data, right? So this is meta-analysis of studies that have been published already. So that sort of aggregate of all that information was they don't tend to.
Yeah.
So, I mean, one of the things I do is I run a health awareness conference. So every year it's called Let's Talk About Black Women and Breast Cancer. And one of the things we talk about is types of surgery, right? So that they know what the options are and what reconstruction means. Because again, with black women, they have worse outcomes anyway from breast cancer, which is the reason why we run that conference. But also they tend to have more aggressive and they tend to get it younger. Okay. So the surgery or the treatments that they may need to influence their outcome may be a little bit more aggressive. And one of the worries, I think, is that you will definitely have a mastectomy. Okay. And so the development and the evolution of techniques which allow you to increasingly be able to offer lumpectomy with partial reconstruction, I think it's quite important that people know about that. Yeah. So that it will encourage people to present earlier because they know that the treatment is not going to be as draconian as they think it might be.
I understand.
They still might need a mastectomy. But again, it's quite important that they know what that means. It does not mean necessarily that you're going to go flat. Yeah. There are reconstructive options. Yeah. The timing may be problematic because of the fact that you might need more aggressive treatment. So we're talking specifically chemotherapy, radiotherapy, but it's still something that's available to you.
Yeah. And it is around that awareness, isn't it? It's awareness and information.
Yeah.
Okay.
I think what I see surgically is that different, and it probably is a bit stereotypical, different cultural ethnicities have got different habitus. So that means the type of reconstruction that might be suited. But even within that, there's different. Sure. So, tall, thin women, for instance, athletic, do they have all reconstructive options open to them? Probably yes, but where the tissue we take, for instance, if we want to do microvascular reconstruction, might be different. They may not have necessarily tummy tissue, but usually they have like thigh tissue, and they're not usually very large busted. So it's kind of matching up, what the breast looks like in relation to where the donor, we call it donor sites, where that tissue is for reconstruction.
Okay, so can we talk a little bit about the NICE guidelines? So as a patient, I hear this a lot. I'll be completely honest with you. I'm not completely sure. I know they are a set of frameworks and guidelines around by which how you work as medical professionals. Outside of that, I don't really know too much. So is this is like the thread for you?
Yeah. So so the NICE guidance we use within our MDT. So our MDT, that's called a multidisciplinary team meeting. And within that, we've got core members. So we've got surgeons, we've got oncologists, and some of those do radiotherapy, some do chemotherapy, some do both. We've got radiologists, we've got breast care nurses, we've got pathologists. Very important you have a pathologist there. And then there's what we call allied health professionals around that, but there's core members. And we use that guidance along with the patient to decide on a treatment plan. And it might be that treatment plan looks great on paper, but then when you talk to the patient and you get to know what their situation is, it's just not going to work. And so we need to modify. So the guidance is there, but But in any walk of life, there's going to need to be modifications depending on the patient that you have sitting in front of you.
Do you think that sometimes the NICE guidance, depending on the trust, depending on surgeons, can they override the need to ensure that the patient is at the forefront of that?
It's guidance.
Yeah.
So it's not it's not a rule.
Yes.
Hard and fast. You break it, you go to jail. It's guidance. And so there will be patients that do. A lot of patients fit nicely into the mold.
Yeah.
But there are a fair proportion that don't. I mean, that's the point of that MDT, right? Is that we, as professionals, as experts in our fields, we discuss it and we draw on the guidance to go, okay, well, look, we can actually access this instead, right? Because it doesn't say you will do this. It goes and there's lots of flexibility within that. So it might be that we go, well, for this one, we're going to do A, B, and C, but for this one, we're going to do X, Y, and Z.
Yes, I understand. I've got one more question. Have you ever had a situation where you have had a patient absolutely categorically want to do something you think is not the right thing for them, or they've got really strong opinions about something that is almost in conflict with what, you would recommend?
Yes.
Okay. How do you manage? How do you manage
this
it?
This is life.
Yeah.
Even within life, we have people. You recommend stuff. You think you're like, come on, this is great advice. Why would you not take it? And they're like, I'm not taking that. Don't want to do that.
Yeah.
We do see it.
Yeah.
We see that there are patients that I would say, look, you've got a cancer. We recommend chemotherapy. We recommend surgery. We recommend radiotherapy. They go, thank you very much, doctor. And they go, and we never see them again. They go off and do something different.
Okay.
Yeah. Or they go off, and the next time I see them, they've got progressed disease. And I'll go, well, what happened? And they go, well, some go and try different alternative therapies. Some just couldn't deal with the diagnosis. And actually, it was only when it became... Because a lot of women that are diagnosed with breast cancer are well. They're not unwell. They feel a lump. They're doing whatever they normally do, and they feel a lump. So they're well. And so for some, they don't believe it to be true.
Okay.
Or they just can't process the fact that you've just told them they've got cancer. And so it's only when it's really causing them a problem that you'll see them again. So yes, we do have patients. Or there'll be a patient where I go, look, you're not a great candidate for this type of reconstruction. Well, it's the one I want, but I don't think you're a great candidate. And for me, it's a really simple solution. I'll go, I think you need to get a second opinion. I'm not offended by that. You need to go and see someone else to get their opinion. And you can have that within the hospital if you want, or you can have that outside of the hospital. It's entirely up to you. So I do not take offence.
Yeah.
I'm like, you need a second opinion. Yeah. This is you. This is your cancer treatment. You need to do this for your own peace of mind. Because from my perspective, when that patient goes off to sleep, they need to be happy about what's going to happen while they're asleep.
And you also need to be happy about the thing that you've said to them, right?
Yeah.
So that, to be able to sleep soundly as well. And I think that's great to be able to actually say, look, I think you need a second opinion, because we forget that actually we're, entitled to a second opinion in anyway. And sometimes it comes back to that feeling of, I don't know if it's gratitude, or I don't want to rock the boat. I don't want to upset potentially someone that I've got good rapport with by going, well, I don't agree. Well, so there's a lot of reasons why potentially we don't get a second opinion, but we know that.
But it's important enough for you to want to raise it.
Yeah.
Right. So then we need to address that, because if you just go, well, no, you're going to have this becomes a problem as well.
I have one final, it's a closing tradition we ask our guests. But if you were to give somebody a piece of advice, somebody who was at the start of their cancer journey, and you can put whichever hat you'd like on, but what would that be?
Don't be afraid to ask. Literally, just don't be afraid to ask. I tell patients, sometimes it's really hard when you're in the consultation room. Actually, it happens to all of us in different walks of life. You're like, right, I've got a plan. I'm going to go in. I'm going to go this, and this. It's all going to get done. I'm going to come out, and it's all going to be great. And then you go in, and you're like, I can't remember anything that I was going to ask, actually. None of that. And then you get home, you're like, we covered none of that. So when a patient sits down in front of me and they pull out, I had one with a clipboard. I loved it. She came out with a clipboard. And normally you give them loads of information, and very few patients read it and really go through it. And she had done this. And she's like, on page 13, it had said this. And she went, honestly, our consultations are, 15, 20 minutes, whatever. But I literally just left her. Because I thought, if you've taken the time to go through this booklet and point by point written down things that you want the answers to, we're going through it. And she just was ticking out. I thought, this is brilliant. She's just tick, 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 tick. And I think that's what patients need to do. Because it's a lot.
There's a lot.
So you write down whatever you want to ask. And if it helps to just say, okay, well, I'm just going to read it, because sometimes people are embarrassed about stuff. Or bring someone who's not going to be embarrassed to ask the question for you.
Yeah.
Because again, that's the other thing I have. They'll go, well, she's not mentioned it, but actually when we were at home, one of the things that she really thought was important was this. And normally there's a bit of an embarrassed look, and I'll go, do you want to know the answer to that question? And they're like, well, yeah. And I'm like, okay, well, this is the answer.
I really like that. And it's simple, but it is about just asking the question. And if you can't, make sure you've got someone with you who's up for asking the questions, because you're right, those questions will come and bite you on the backside as soon as you step out.
Yeah. Don't always bring a clipboard though, but yes.
Don't always bring a clipboard.
Little notebook's fine.
Georgette, thank you for your time. I've really, really enjoyed this conversation.
Pleasure.
I know it's going to be so helpful for people listening, whether or not they're going through their own journey or they're supporting somebody else or other health professionals. Just hearing
they're all going to thank me again. Yeah, let them bring clipboards to clinic.
Clipboards. Georgette, thank you for your time.
Pleasure.
Cups and Courage shares honest, personal stories of people affected by breast cancer. The views you hear are those of the guests and host and don't replace medical advice. If you're concerned about your health, please speak to a doctor or healthcare team. Cups and Courage, the podcast.